Hello, everybody, and welcome to this evening's webinar. My name is Craig Norman, and I get the great opportunity tonight to be the moderator for what we think is going to be an extremely interesting panel discussion. The title of tonight's topic is related to debunking myths that are running rampant, if you will, within the specialty contact lens field, and let the panelists be able to discuss what those are and what the real issues are related to those topics. So as far as our panel, I'd like to welcome them. Dr. Lynette Johns is the Director of Clinical and Scientific Affairs at Visionary Optics. She's been a key player in the specialty contact lens arena for, it's tough to believe, but around 2 decades. She's an international educator and talks on scleral lenses, irregular corneas, and ocular disease. You may know her also as the co-author of one of the seminal books on scleral contact lenses. She's done a number of things besides her recent appointment here at Euclid, but she was recently an investigator at Mass Eye and Ear and a research associate at the Harvard Medical School Department of Ophthalmology. Welcome, Lynette. Thank you so much for being here this evening.
Thank you for having me.
Randy Kojima is also joining us. Randy's a lead researcher and global educator for the CAT Design Group. He also serves on the faculty of Pacific University College of Optometry. He's authored many different articles, and if you've had any interest in corneal topography in the last 20 years, you've heard him speak at least a dozen times. So Randy's very prominent in the corneal topography field. Randy, welcome.
Thanks, Craig.
And then last but not least is Jackson Lau. Jackson's a senior manager of professional relations at Euclid Vision Corporation. He's previously a residency trained at ICO, the Illinois College of Optometry, around 10 years ago, I think, give or take a year or so. Besides working at Euclid, he also maintains a specialty contact lens practice in the Bay Area. Jackson, how are you doing tonight?
Doing great. Thanks, Fred.
Okay, great. So if we can go ahead and get started, that the panel's going to address these issues. The way that we came up with the questions to address is we talked to the lens consultants at Euclid and at Visionary Optics, and kind of questions that come in from doctors, from other kinds of employees that are out in the field for this company as well. And they pose these things that they're dealing with on a routine basis, so that these questions have basically been generated from the area of interest of the actual contact lens practitioner. So let's start off with the hot topic that is in the industry today. It seems like you can't open up anything without AI, artificial intelligence, being part of the topic area. And this was a question that came up a couple of different ways as far as AI and what role will AI have in specialty lenses? Does it really have a role whatsoever? Randy, how about if we start with you?
Yeah, I think interesting times, isn't it, that so much of what we collect in the clinic now is digitally recorded, and being able to assess those images that we've collected allows us to do a lot of work with them. For instance, we could look at the relative conjunctival whiteness. We could look at the injection and grade it. We could have the instruments actually define for us the tear meniscus height, define for us the meibomian gland and its dropout. And then, of course, with corneal staining, that's another. So there's quite a few things that we can do with some of this digital image capture. And I think it's going to make it even easier for us going forward to document and define, grade, and treat our various conditions that we're seeing popping up. And then on the topographical side, it becomes very easy for the instruments to learn based on eye shape. So as an example, we could take that topography on the left and we would ask ourselves, is this a diseased eye? And the AI will be able to define for us through numerous metrics if this eye meets that threshold of irregularity or not. We could use the elevation map to understand when eyes are so far beyond the tipping point of a corneal GP working. And then I think the one that we might see relatively quick is using the post-treatment map in topography, or the subtractive map in orthokeratology, to define, is the lens centered? Is it maybe a mild superior decentration, or moderate or severe? That's one of the areas where practitioners really struggle with when they're new to ortho-K. Is this a good outcome, or is it a bad outcome? So pretty incredible what AI can do. We just need more numbers. I've talked to numerous experts in this field, and they're saying, your minimum numbers that you need has to meet this threshold. And I think many of us are working on getting to that appropriate threshold that it can learn enough.
And those numbers are thousands upon thousands.
In some cases, yes, but some of the experts are saying it could be much lower than that, depending on the type of collection that you're doing. What is the image that you're assessing? But I was surprised, Craig, that one AI expert that Euclid had on their team was talking about hundreds and not thousands. So that was a real surprise.
Mm-hmm.
And speaking for scleral lenses, I was originally approaching this topic and thinking, well, AI, how is that going to fit a scleral? But it's already doing it with profilometry. So this is an example of a profilometry map that's scanning all the different meridians. And basically, we're taking a virtual mold of the eye and being able to zap that into a lathe and cut a truly free-form lens. And here you can see with the next images how unique these shapes can be compared to just a standard spherical, concentric spherical lens, or even just with toric haptics or quads, how unique these different AI profilometry driven designs can be. And so I don't think it'll replace the human factor of, designing certain parts of the lens, or at least being able to evaluate the lens to make sure it's fitting appropriately. But it'll definitely make our lives a lot easier, for sure.
Jackson, did you have anything to add there? Maybe from a clinical side, or?
Yeah, no, I think Randy and Lynette covered most of it. I think from everything we're reading these days within the entire ophthalmic space, there are so many different treatment algorithms already being taking place in the dry eye space, glaucoma, retinal disease, like detection, like diabetic retinopathy. So I think this is going to encompass every part of our lives, and even into the contact lens space as we speak.
Yeah, it's an exciting time that this information, to know that it will be of detail, will be evidence-based on numbers, and will simplify people's lives significantly, I think, going down the road.
Could be interesting is if AI could determine a base curve in power. That is one thing that we still need a diagnostic lens to do for those irregular corneas. So that would be really interesting if there'd be an algorithm that could aid us in that effort.
For sure. And we didn't even touch upon, for instance, for us in the contact lens field, where this is going to play such a big role in fabrication as well. Mm-hmm. So, okay, excellent start. So this is kind of building from this previous question on AI, because we discussed a little bit about topography. But we hear this very often, that topographers are all the same, that they are lumped into this one bucket. And that it appears, with the sophistication that we have today, that may not be the actual case. Randy, can you touch on this a little?
Yeah, I kind of geek out on topography, and I just love all the technologies that we have access to. And I think it's true to say that every topographer has its own strength. They are not all the same. Certain topographers are going to favor specific environments or specific applications, and there isn't any one topographer that can do it all. They're all so individualistic in their features and their applications. So it's really incredible that we have this much technology. I think, Craig, you and I will remember a time when the first topographer launched, and that was all we had. And now here we have this list that it may not be complete of all the topographers that are out there. That's how much technology exists today.
Yeah. Yeah. Very, very interesting. And it's especially interesting putting together a list like this, how many there are that are available.
Absolutely.
Domestically.
If we look at Placido technology as an example, it tends to favor the contact lens oriented environment. Its software is really built to assist with contact lenses and kind of general practice. Your profilometers are, of course, going to be used very much for the scleral application. And then you have tomography that's so great for the surgical environment with its ability to measure the back of the eye and corneal thickness. And the kind of newbie to the market, arguably profilometry is the newest, but from the application of topography, OCT would be that new kid on the block where we weren't historically using it to measure eye shape, and now that's where it's going. So we've got a lot of great technologies. I can speak for the environment that I work at, and I'd love to hear Jackson and Lynette's thoughts. At Pacific University, our team is very focused on the contact lens side. So the tool that we prefer to use is the Medmont Meridia Pro, because it gives us easy access to corneal shape data. It gives us lots of contact lens oriented tools, software, and then its ability to image in white light, cobalt, and fluorescein. Our ability to document as well as analyze is really powerful as a tool. Lynette and Jackson, what are your thoughts about topography, and is there one perfect instrument, for example?
You want to take that, Lynette?
Okay, yeah, sure. When it comes down to scleral lens fitting, having a combination of everything is really helpful. Having the profilometry, like we showed before with those unique design lens, well, that's really helpful. But being also able to show central clearance or limbal clearance, even the landing zone with OCT, and even just monitoring disease with topography, with standard topography and tomography, it all comes into play in scleral lens practice for sure.
Yeah, and from my short perspective, I think obviously I deal a lot with the myopia management and ortho-K population, and so we really value the data that we get from a lot of the smaller cone topographers like the Medmont, where it really helps compared to some of the larger cones where topographers where we may have more extrapolated data. But I think speaking from working with our lens consultants on a day-to-day basis, they always share some of the pros and cons of different instruments, and there's not necessarily a perfect instrument out there, but certainly it's important that practitioners out there are analyzing their instruments in a more analytical way, not just to get a machine to order a lens, but if you really want to do any significant level of myopia management with ortho-K, you want to be able to troubleshoot properly. Having that extra data is going to help long term. And so being critical of your choices on a topography standpoint, I think is very meaningful if you want to dive into specialty contact lenses.
Absolutely great points. I would just like to echo one of the things that Randy said. The imaging capabilities is really what I think are fantastic today. You mentioned the Medmont Meridia, for example. For me, myself, my whole career, we've been trying to get images quickly, easily, high quality, inexpensively, all of those things. And to have it built into an instrument that allows for other tasks as well, and to have that added area of photography is terrific. Okay, excellent. So fitting ortho-K is too complicated for my practice. This is something you hear from new practitioners very often. That they feel a little uncomfortable regarding that. What do you think about that, Jackson?
Yeah, so working heavily in the myopia management space day in, day out, not just from an industry perspective, but also working in the heart of the Silicon Valley with a very high Asian population. I'm always thinking everyone's doing myopia management. Everyone out there is doing it. But I was really surprised. I think there was a paper that came out of Academy last year that said roughly less than 20% of ECPs are providing any form of myopia management. And as I go out in the field sometimes with our team, we meet a lot of doctors, and it's probably true that there's probably a lot of doctors who are not focusing on myopia management, and in particular, maybe ortho-K can be a bit daunting. But I think if we think about all the opportunity, all the myopes that come through our office, there's just a tremendous opportunity for us to improve our office revenue, but also meet the standard of care that we now believe is to be true, is just doing myopia management. So this paper that came out last year by Michael Lipson, I think they listed some of the top reasons why more doctors are not prescribing orthokeratology. And at the top of the list, time, probably lack of time, and the steep learning curve was probably one of the main reasons why many doctors are not approaching orthokeratology as opposed to, let's say, a soft lens. And so I would argue that investing in a specialty like myopia management and focusing on ortho-K can be one of the best things that you can do for your practice and save on time down the line if you invest in the learnings for it. So, we would much rather, in our office, we would much rather see 5 to 10 ortho-K patients or specialty contact lens patients versus, 20 or more routine exam patients, right? And I think the issue is that many doctors these days we're using, we have vision care plans that dictate that we have to see patients every 15 minutes, every 20 minutes. And so we don't even feel like we have an extra 5 minutes to talk about the benefits of slowing down myopia, right? And so I think if we think about this as a long-term investment, and you can always, let's say if you're running a very high volume practice, you can set up your myopia consultation similar to how you would set up like a baseline glaucoma testing. You wouldn't try to cram everything all in during your complete exam, right? So you would set up a separate time to do your testing and then having that consultation with the patient. And in this day and age with technology, we, personally, we also offer virtual consultation so that both parents can be involved in listening to, the pros and cons of, intervening with myopia. And this way I can show them a little presentation virtually online as well. And so I find that this really helps with keeping my office flow steady. I can really give my patients the time that they want to learn and understand the concepts, because eventually I can actually see less patients by having more high revenue generating patients who are doing specialty contact lenses. I can spend more time with them and not just, have another routine patient and sell another pair of glasses. And so I think this is where we have to shift our mindset in terms of the value of time, in terms of what we value in our day-to-day clinical practice. And so from a learning perspective, learning curve perspective, nowadays, I think almost any company, especially for ortho-K, we make it so easy for practitioners to design lenses. You can simply zip off your topography files and your refraction, and you'll be sent a lens that's going to be working well, over 80% of the time. So when we have our fourth year students who come through our practice and they see, how simple that may be, you just need to know how to look at the cornea, collect refractive data, and send topography data. Nowadays, all the companies can have excellent lens consultants that can guide you through the process. I think a lot of these barriers to fitting ortho-K and doing proper myopia management, they're significantly reduced, and therefore, and in particular with instruments also, on Randy's side, with the Medmont Meridia Pro, you can send all the videos of the lens fluorescein patterns and the videos with the lens movements and topography. It just makes things so much easier to fit ortho-K in this modern day and age. So I think many practitioners now are moving towards fitting specialty contact lenses and particularly ortho-K, and I think now's the best time to do it.
Excellent. Guys, anything else to add to that?
Yeah, I was going to say that I remember a time when the expertise really needed to be in the practitioner's office. They needed to be able to assess and have the knowledge to know what to do next when it's not working. But now in ortho-K, especially since it's so much technology based and topography analysis based, as Jackson said, you're able to communicate the digital map to the consultant. You can send the fluorescein pattern images or video, and whatever number of fits that you see and whatever the specialty is, let's say it's a scleral or it's ortho-K, the consultants at the lab are seeing 10 times that in a day. They're dealing with that many more. And their understanding of the construction of the lens is just so superior to anything that we can achieve. So they're able to really walk you through the whole process. And I think that's something that Jackson said that's so powerful. If you're intimidated by what are the procedures in ortho-K, how do I start with initial lens when that lens is fit post-wear, when do I need changes? I mean, you have people that will walk you through this entire process. It's never been easier to be able to fit a complex lens like orthokeratology.
Excellent. Somebody did ask a question on what was the name of the topographer again. I'm thinking that you're referring to the Medmont Meridia was the one that was brought up, talking about the ability to capture images from it as well. Okay, corneal topographers are not beneficial in a scleral lens practice. Well, we've been talking about ortho-K, mentioned topography. What about on this side relative to scleral lenses?
Yeah, I mean, this one would seem so counterintuitive, right? That we could possibly use corneal topography in the fitting of scleral lenses. I mean, it's a corneal topographer. It's not a scleral topographer, but it actually is quite useful. Craig, if you don't mind advancing to the next slide. You know, our ability today to capture what's called a composite map, where we fill in all the space on the cornea, it's actually quite useful in estimating the height of the anterior segment. So using a Medmont, you're able to do what's called the composite eye capture, where you have the patients look up, that pushes the rings to the inferior portion of the cornea, have the patient look down, that pushes the rings up, nasal, temporal. You're basically covering 100% of the cornea with your data points. And then that builds that bigger eye shape. And where that's useful is on the next slide, where we can use that peripheral corneal shape to understand the depth well into the sclera. So here you can see that red arrow showing you the depth of the cornea to a 10 millimeter cord. But if you can pick up the angle, that's the yellow part, if you can pick up the angular surface of the peripheral cornea and limbus and sclera, if I understand this point, I can measure all the way in or all the way out to the point where our scleral lens might land. So it's actually really useful as a method to determine the initial lens parameters. Craig, the next slide. So surprisingly, you can use a corneal topographer to help you to determine the initial depth of lens, which is ultimately one of the most important things that we need from our analysis, whether it's corneal or condition or whatever it might be. How do we start with that initial trial lens? And this is one of those ways, because the instrument will give us an estimation of the height of the anterior segment. The other piece is that you can also then use that knowledge or that analysis to place a theoretical lens on eye. And that's what you see in this right image, where we've put on a scleral lens in this theoretical environment in the contact lens software to assess, are there points where the cornea would be high or we'd be crashing into the limbus too early? And this is a really powerful diagnostic piece, because we haven't had to clean and condition a lens. We haven't had to place it on the patient yet. We have an understanding of how it might fit before it's actually gone on eye. And the next slide. So ultimately, what we're all trying to get to is a more efficient process of getting to that initial diagnostic lens. Lynette, what are some of your thoughts? Is it crazy? Am I just being a nut about corneal topography and that it actually has no application in scleral lens fitting?
So previously I used to think, now because we're vaulting all over the cornea, so it's the only reason that I would use it was for managing and monitoring disease states. But now I'm more obsessed with the limbus, and I think a lot of practitioners have also become more obsessed with the limbus. And a lot of lens designs are requiring an HVID just for your starting point of your lens. And the fact that, even on the last slide that you showed that had the simulation, you can see based on the simulation that was crashing down on the limbus. So, you wouldn't even have to put that design on the patient's eye if you had another lens that was uploaded into your topographer that would provide the simulation. Because if you have a large HVID, you might not be able to use a certain design because it's going to start crashing down. And again, with the topographer that we've been mentioning, the Meridia Pro, this is an example of an image that you can see the great fluorescein appearance and just the topography. There's color images just to the topography, and you can take great images using this technology to monitor your fits, not just looking at the clearance, which, as you know, the ideal clearance with the fluorescein patterns is sea of green, but you can monitor compression patterns. You can take images of, if you had a dry eye, the staining before the lens was fit, and then how the patients progressed with wearing a lens. There's a variety of uses, especially with all of the features that different topographers have. So again, like before, I would say, but now knowing all the technology and actually it being able to determine an estimated height can actually guide a practitioner not only with the HVID, but what's the starting sag that they can use, that especially if they don't have a profilometer available to them.
Okay, good. Jackson, anything to add?
No, I think we covered it pretty well.
Hey, Craig. Sorry, just one other thought for the audience. We think about using the instrument before we fit the lens, but we can also use topography after we fit the lens. We can do tear film analysis over the anterior surface and see if the lens is appropriately wetting. Is that a reason why this patient washes out really quick in terms of comfort? If there's some weird responses visually, we can do topography over top of the lens to see if it's warping or bending on eyes, the lens inadequate thickness and needs to be thicker to maintain that ideal spherical shape to correct our regular astigmatism. So there's plenty we can do with the topographer that's both before we fit the lens, but also with the lens on eye.
Sure.
I agree with the warpage. Nobody has a radioscope anymore, and that's the best way to see if the lens is warped. So if you do an over topo, you definitely can pick up on that.
Okay. So building upon that, here's another myth that you have to use an OCT to fit scleral lenses.
Yeah, I feel that it's definitely nice to have, but you can have the basics without that technology. It's not a barrier to start fitting scleral lenses. So the basics that you can see here is having a diagnostic set, having plungers, the innies, which are the large plungers, the outies, which is the usual corneal GP DMV plunger, fluorescein. I have a picture of paper toweling because the patient's going to get wet and filled with fluorescein all over their shirt. So you got to give them a lot of paper toweling. But your slit lamp fluoropter, my favorite is my RET. I can do my over refractions really quickly. And just using a transilluminator, when you first put the lens in, you got to do a bubble check because bubbles don't burp out with a scleral lens. So you want to make sure that there's no bubble before you evaluate the lens. But it's a great way to get a bird's eye view of the scleral landing zone and see if there's any scleral patterns. If you're looking for toricity, you can actually see compression in different meridians. And that's really helpful because a lot of times when you're behind the slit lamp and behind the magnification, you end up getting lost in the details. And this is your first assessment. Is the lens decentered down? Is there, a toric pattern? Are you smushing on a pinguecula? Things of that nature. And this is just some images. What you want is you want central corneal clearance or apical corneal clearance. You want limbal clearance as well. And you want that lens to just land gently on the sclera, on the conjunctiva overlying the sclera. Your patients aren't going to come in with fluorescein. So if you don't have an OCT, it's a little tricky in the beginning, but you can evaluate the clearance with your slit lamp, just using the light to your advantage to see the front and back of a scleral lens without fluorescein. And in a pinch in the beginning, if you're really new to it and dependent on fluorescein, you can go ahead and dispense some strips to your patient, have them dip the strip in their lens in the morning, and then come in for their follow-up to aid you in helping them with their fit. And additionally, in the next slides, you can see how fluorescein really will aid you in, seeing if there's on the left, that's a graft-host junction contact on a proud graft. And on the right, you can see the keratoconus is smushing into the back of the lens. So, you can pick that up without having an OCT available. The other thing is that you can actually evaluate when the lens comes off, how the eye appears in general, because the eye will always leave its secrets, of how the lens was fitting. So you can see in the upcoming slide that there's things that you can use when you have corneal contact, you can see staining after the lens comes out. So if you miss it when the lens is on, you don't have to have the patient come back. You can just take a look with the lens off. It's going to leave its mark. And again, this is another graft-host interface that's proud and with staining. And you can see that it's touching with the second image. And then when you get a little further away, this is serial images scanning across, it starts to clear. So it just takes some subtle observation. But if you miss it, you certainly can pick up on it when the lens comes out. And then there's other cues to the conjunctiva. If there was impingement, as you can see in the center, when you take the lens off, you're going to see that arcuate staining. And if you had compression, when the lens comes off, you're going to see a rebound hyperemia. And, in those patients that have those, beautiful lumify white eyes, you take the lens off and it starts flaring up red, that you were compressing somewhere on that lens. So again, there's subtleties, and OCT is valuable, but it's not necessary when you're getting started. It's just something that's really helpful to relay to consultants and just to monitor your fits as well. But again, I don't think it's a big barrier to get started with scleral lenses. I think the first barrier is just making sure you have an appropriate diagnostic fitting with that, because with scleral lenses, you can't empirically fit them. You have to actually put a lens on to evaluate it, unless you have a profilometer.
Okay.
And I would add, Craig, I think when we have our fourth-year students who rotate through our clinic, I always encourage them to almost always do, if they can, do the entire fit without an OCT. There are so many things that the OCT can be deceiving, whether it's at the limbus, whether it's at the haptics, and not having those pure observational skills. I don't know if that's just because we're a little bit older, having fit scleral lenses back in the days before we were using OCTs, but there's so many things that you can miss, and such as those images with the limbal staining, you can't really see that with the OCT sometimes, right? There can just be apposition where it's just tangential to the surface, but without actually knowing the observational skills, once you take out the lens, those are the things that will really help you with scleral lens fitting. It's not so much what does the OCT image show you, because that's just one little snapshot of the cornea. So I think it's so critical for practitioners to learn the basic skills and then using the OCT as that adjunctive tool to help with some of those decision making.
Hey, just one thing to add. I think the team is so right that you've got to rely 100% on your slit lamp. In some of our testing, we were surprised to find the OCT was way over or way underestimating the apical clearance. And, these instruments weren't designed to measure lens, ton of fluid, and then the cornea. So it's no surprise that at times they can burp, and certain instruments just get it wrong. So having it as a backup is great, but relying 100% on the slit lamp exam is really important. I think the team said that very clearly.
Okay, let's go back to Ortho-K here for a second, and let's talk about this. Is Ortho-K effective only for high myopes? Jackson?
Yeah, I can take this, Craig. So I believe this myth may come from multiple factors. One, it could be that when, let's say, new Ortho-K fitters are looking at, let's say, the fluorescein pattern here, it may not look as obvious like a perfect bullseye pattern when you have a lower level of myopia. And number two, it may be that once the treatment has taken place overnight, the topography may not be as well defined as that perfect red bullseye ring. So those are maybe some reasons for this myth. Other reasons may be because perhaps there's this assumption that there's this one-to-one relationship. If you're treating a -1 diopter myope, that you're roughly going to get about a diopter in that red ring, that peripheral add steepening that's akin to, let's say, like a multifocal soft lens. So, I think these ideas may also come from perhaps anecdotes that maybe if we're managing lower myopes and we see the progression, that we think it's not as successful as the higher myopes. But what we may not be realizing is that the lower myopes are also potentially the younger patients. And as if you look into any of the research, we'll find that age is one of the biggest predictors of myopia progression. So there just may be a lot of confounding factors that's leading to this myth. But if you look at the research as a whole, if you do any kind of systematic review, there's no evidence that Ortho K is less effective for lower myopes. It tends to work for myopia at any level. And so keep that in mind. There can be individual factors that are different between, patients. So you certainly can't treat patients as if they're, like a study subject. You have to treat that individual patient. And so ultimately, be mindful of managing that patient. If one treatment's not working, certainly you may need to alter it to a different modality. Let's say if you're doing Ortho K, you may need to switch to multifocal soft lenses or add on atropine. But I wouldn't consider this generalization that a certain treatment's not going to work for a certain level of myopia. I think that's been debunked pretty consistently. But we still do hear this in the field as far as ECPs having this perception. So we just wanted to clear that up.
So Jackson, we know that the approvals, the FDA clearances in the US are at around 5 diopters of myopia. Do you ever look at a child that is a -8 and you want to correct them up to 4 or 5 diopters? Is there any benefit of that at all?
Yeah, that's done pretty consistently these days in a lot of high volume offices where if you look in the literature, there is still some benefit and value to doing what they call partial correction, Ortho K, where even if you were to correct them from, let's say, -8 to a -2 or 3, if they were to be corrected the rest of the way with either soft lenses or glasses, you'll still have an overall positive benefit in slowing down their myopia. That being said, a lot of times those parents and children may not be as interested to not only wear a lens at night and also wear a lens during the day. But if you look at the literature, there actually still is a benefit long-term in slowing down axial length and myopia progression by doing partial correction.
Okay, great. Scleral lenses are only for severe ocular conditions.
Yeah, I think that is often the theme of things. Everybody thinks that it's for keratoconus. That's like the first knee-jerk idea that, that's what scleral lenses are for. And here we've got that laundry list of all the different types of irregular corneas. You've got the naturally occurring ectasias and post-surgical corneas, all the way to dystrophies, degenerations, and scarring. So not only that, but you also have, ocular surface disease, and that's got its own huge list as well, which you can see on the next slide. It has, dry eye is all part of it, but Sjogren's, graft versus host disease, these are some heavy hitting diseases, and a lot of the experts fit these. A lot of the hospitals see these. Sometimes in private practice, you don't see this list of disease, but they're out there, and what do you do when they show up in your chair? You have to treat them. But going to to make it simplified, we can just look at them as buckets. So instead of trying to memorize all of these different diseases, we just put them into buckets. Anybody that's got an irregular cornea is going to live in the visual rehabilitation bucket. Anybody that's got exposure, Bell's palsy or, things like that, bad ocular surgery, bad blepharoplasty goes into the protection bucket. And then for the dry eye category, the ocular surface disease, you got lubrication. But there's a whole host of people that drop out of soft lenses for various reasons, because they've become presbyopic or because they've become drier. And that's where I like to put the almost the normal category under the visual rehabilitation bucket, with high ametropia, if you have a high myope that's dissatisfied with their soft lenses, you can definitely improve their vision with just rigid optics. And for the presbyope that's actually becoming really dry, there's a lot of optical choices with scleral lenses, and you get a twofer. You can actually give them, a little bit more lubrication to the eye while also correcting them visually. So I think the majority of people are fitting these lenses for disease, but normal corneas don't have to be ruled out. And you still can get some coverage for the high ametropia for as medically necessary lenses.
Fellas, anything to add?
I was going to say that I think this topic of Lynette's, to think about it for some of these visual needs. How many times have we fit a scleral lens for a patient that just wasn't getting the quality of vision, and we were able to put that lens on with that huge anterior surface spherical optic and just eliminate the aberrations. It's been a great tool to have as a last resort for the relatively normal eye. We've used scleral lenses for Olympic shooters as an example, that needed a next level quality of vision. So these are all normal eyes essentially, but they're just not getting the optics that other options are providing. So there's certainly plenty of application outside of just the crazy irregular diseased eye.
Definitely. I'd like to remind the viewers also, if you have any questions at all for our speakers, type them into the chat box and we'll try to answer them at the end of this evening. Let's talk a little bit about dry eye. So dry eye management requires a significant investment in my practice. Is this for real or not?
Yeah, I'll take this, Craig. So I think for anyone who's listening to this webinar, there's probably at least some interest in specialty contact lenses. But just like any regular run-of-the-mill soft contact lenses, I think we're all familiar. If we don't have that good foundation of good tears, good ocular surface, we're not going to be successful no matter what we try. And almost alluding to the previous topic, scleral lenses may not work for some normal corneas with severe MGD. Sometimes there's just not the proper environment for any kind of contact lenses, and that's something that with time, with experience, practitioners will notice. So dry eye is so significant in terms of the sheer volume of people that it affects. So that's why it's so critical that for anyone hoping to build a specialty contact lens practice, that we learn how to manage and treat it. And so nowadays, what really helps us, certainly we can learn a lot in school, we can attend CE lectures, but at its core, dry eye management, in my experience, there's a lot of psychology behind it, and you're typically managing that individual person as much as the disease itself. And so I think it's so important that you have the proper diagnostic tools and visuals that will help the patient understand their treatment and the disease itself. So I find that having the ability to show, for example, this bottom left here, the myopia image, similar to how dentists take routine x-rays, every 6 months or every year. It's just part of that care that you're expecting. And so it actually can show objectively what's happening. By us doing these routine, let's say, myopia images, we can actually show patients, hey, this is what's happening in your eyelids. You have, for example, 50% loss of your meibomian glands, and the patients will perk right up. As opposed to if you just told them, hey, you have dry eyes, then that's not quite the same kind of conversation. But having that visual, you can show them the myopia with the cameras that we have nowadays. You can show the lid disease that's occurring, the blepharitis. You can show them the staining patterns, whether it's with lissamine green, whether it's with fluorescein. This really, really helps with patient engagement in their condition. It helps with buy-in. You can send them out with reports. You can give them the treatment plans, and it really helps with long-term compliance, and ultimately can help grow your practice as well with word-of-mouth referrals. Versus the other office down the street who doesn't that don't have that kind of technology to share with their patients. And the reality is that the investment in these type of tools is not that high. Certainly, with the MedMont, they have the Pro version that has these anterior segment imaging. They have all these extra capabilities that can really help you start and grow your dry eye practice. And ultimately down the line, I think there's the opportunity to consider other tools like, IPL or LipiFlow. Certainly those can take a significant more investment, but just to get started, just to really manage dry eye to a really, confident level, I think having these base level tools, and I think Randy can share a little bit more about the tools available with the MedMont, can really help your dry eye practice grow significantly.
Yeah, we wanted to share this one test called the tear film surface quality analysis. And the principal thing it does is to tell you the point where you have tear film breakup in a non-invasive manner. There isn't any dye put into the eye. It's the way the DEWS 2 report suggests to us that we want to assess as one of the metrics of dry eye. We want to do the assessment in a non-invasive manner. So what you're looking at here is the topography up above is showing you dark blue, or blue is where the tear film is smooth and even. The hot colors are where there's breakup. And if you look down below at the graph, that vertical blue line there is showing you the point where the tear film broke up. And then, as you can see to the right of that line, you've got this slope of how much more surface area the eye is breaking up. So you're basically watching in a very objective manner the point that the tear film breaks up and how it degrades over time. So a really powerful little tool. Remember, this is a corneal topographer. In theory, it's for our contact lens application, but as Jackson said, we have the ability to do meibography, to look at staining in white light or in cobalt. We have the ability to look at lid margin with the white light analysis. And there's this for us, not just related to contact lenses, but especially in dry eye.
And the beauty of it is that so much of it can be staff driven. You can train, one or two, really eager technicians of staff in your office, and they can really drive a lot of the instrumentation so that you as the ECP can just analyze the data, recommend treatments, and, give your patients really, really high level of care without a lot of, again, investment on your own time, chair time, doctor time.
When I see these discussions about tear film, it's really fascinating to me how sophisticated it is, in particular since I grew up in the era of the Schirmer strip, where you somehow try to make sense out of that doggone thing working or not working. And so it does show that it is very, very high level, these tests that are being done, and they really work well into the show and tell part of the examination.
We're still in that era, Craig. I don't think we've left the Schirmer's era.
No, they're still available. Okay, K readings are still the best thing to use to fit contact lenses.
Oh man, guys, if any of you in the audience know me, I'm just crazy about topography and taking 2 data points when you have the ability to collect thousands of data points. It's really hard for me to get my head around. I remember a point when 100% of what we did was based on Ks, and the most powerful thing K readings does for us is tell us the corneal astigmatism. But as you can see in these 2 images, there's just so much data that's missing in understanding what this eye might need for a contact lens. Just having those data points averaged on this axis and on this axis, it's just such limited information. And our next slide. If you imagine, we've drawn where the approximate point of K readings would be taken at that, 3 millimeter approximate diameter. And, we're not measuring anything inside of 3 millimeters. We're not measuring anything outside of 3 millimeters, and trying to fit a corneal GP on an irregular cornea, that's going to be incredibly challenging. Soft lenses, certainly we can do it. They're forgiving enough, but when the eye falls outside of the normal range of rate of flattening, then maybe that's one of those cases where we're going to need to refit the patient. And certainly in scleral, as Lynette showed us with the fitting set, that isn't chosen based on a K reading. That's chosen based on the general condition. So that's how useless K readings are, at least for the irregular cornea. We can certainly use Ks to build a ortho K lens on a normal cornea with a normal rate of flattening, a normal eye shape. But when we're talking about anything complex, they're just so useless. And I think on the next slide, it's kind of it gives you some perspective that, here we've got corneal topography that's measuring 100% of the cornea. So 15,000 data points of information. And in the right map, we have a scleral topography, a corneal scleral topography to understand, is this a symmetric, a toric, or an asymmetric eye? And, leading us in the right direction. Certainly K readings are not going to predict the correct lens for a irregular cornea and in a scleral. And, here for these irregular cornea patients, K readings are, near useless as a starting point. I remember Craig teaching me way back when in the irregular cornea, possibly one of the best things you should do is put your finger on the middle of the trial set and start with that diagnostic lens. If it was a corneal GP, that's probably a better point than if you took the K readings and used it as a tool for fitting the lens. But again, I don't want to suggest that we can't ever use K readings, and that's not the case, especially when the cornea is normal. Then they can be very useful. It's just when it's irregular, I think it's going to be a real struggle to have any kind of first fit success or a high first fit success.
Randy, do you have any idea at all how many corneal lenses are ordered by KSNRX today?
Probably an estimate would be about 80%, because it's assumed that about 20% of practitioners have topographers. But then are the 20% of practitioners have the topographers? Are they the ones more likely to fit a corneal GP? I don't think we know that number, but yeah, it's only a starting point. It's probably going to require a consultant to assist and fine tune those parameters.
Yep. Okay, so here's one that came up a number of times, and that is related to midday fogging. Is it the hardest complication for us to fix in scleral lenses?
So, yeah, this is a very common complication, but I think it can be overcome as long as we're careful and diligent as practitioners, because it's not all the same. So what I'm showing here is you've got debris, but you've got different types of debris that I've seen through the years. On the far left, you actually see these like little white snowflakes, and if you really look at it with high magnification, it's fluffy like mucus particles. Whereas on the far right at the top, you actually see oil droplets, and that's related to meibomian, oils. And then in the middle, which is rare, this is the hardest one that I've always encountered. And this is like watered down milk in the lens. The debris is so particulate that it's minute. So it's really easy to get underneath the lens and trapped. And that I see in atopic individuals. So this is where we have to actually put our doctor hat on when we're looking at these, because when a patient says, I'm fogging middle of the day, there's actually 3 types of fogging. You've got the debris in the reservoir, but you also have potentially the front surface fouling up and getting debris stuck on it, mucus, oils, proteins. And then the worst thing of all is if you have a corneal transplant, you could actually have corneal edema. And so you have to be able to differentiate this and use your diagnostic hat. So if you do have a graft, ask them if they see rainbows around lights. If they see rainbows, that's Sattler's veil, and they have to basically take the lens out because their cornea is becoming swollen, and they need to deturgesce and be able to, clear out. The longer they wear that lens, the worse it's going to be. So you have to put that hat on. And this is just an example of, typical lid abnormalities. You got to treat the lids. You got to treat the patient, not just fit the lens. You've got to treat all of the ocular conditions. So this can create those oil droplets that'll float up to the top. And then one thing that we can't miss is GPC. And that's when I see those fluffy white mucus-like debris. I always flip that upper lid just to make sure that there's no GPC up there, because that can be creating more mucus that gets trapped under the lens. And sometimes all you need to do is tighten your vertical meridian, and then the edge isn't bothering the underside of the lid. So otherwise you have to be very creative in treating these patients, especially with irregular corneas, because they can't be without their lens. And yet usually the treatment of GPC is to take a holiday from the lens. So again, that can be quite challenging. So this is an example of, looking for tear exchange and seeing where that debris from the tears might be getting underneath. And you can see 3 and 9 o'clock look fine, but if you look at 6 and 12 o'clock, you've got all of that edge lift and tears coming in. So that's a spherical lens on a toric eye. And so what we'll do is put a toric peripheral curve on. And so in the next video, you can see the same eye with a toric peripheral curve. And with visionary optics lenses, the diagnostic lens hash mark is on the steep meridian. So this coincides with where that tear exchange was coming in the last video. So putting toric peripheral curves, finding where the exchange is coming in and tightening that. You could put a quad in. If you use visionary optics lens, you actually have what's called a multi-meridian. So you can even put a 5th meridian in if you're getting it between 2 primary meridia. So there's things that you can do to block the path. And, the good old, putting some Celluvisc in the lens that'll block the debris from coming in, or it could be dissolving the debris. We really don't know the function of Celluvisc, but it tends to work quite well in some individuals. So I think it's manageable. I think you have to be creative fitting, and you have to be creative in diagnosing the patients and looking at the whole eye and the whole patient for that matter to determine what's actually happening.
Okay, that was excellent. Excellent explanation. So how about scleral lenses being effective in treating all dry eye conditions? The key word here is all.
Yes, the keyword is all. So here, this is a definite dry eye situation. It's like Oxford grade 4, NEI grade 15. It's up there, and that's on the left. But after 4.5 hours of lens wear, you can see that cornea is nice and pristine. And so trapping the liquid underneath the lens on that corneal surface is very rehabilitative to the surface and supports it. However, there's, aqueous deficient isn't the only type of dry eye, and there's a lot of meibomian gland dysfunction and, mixed aqueous and meibomian gland dryness. And typically, in my experience, I don't know about you guys, but if it's an MGD situation, I haven't found much luck with scleral lenses really benefiting those patients. I find more bang for my buck in the aqueous deficient, where the lens is bathing the cornea. If there's a problem with the oils and everything, you're still going to have that surface to lens friction, and you might run into some issues that way. And if the eye is dry, it just transfers the dryness to the surface of the lens. So that's been my experience.
Okay, I'd like to reiterate again, if anybody has any questions, to please type them into the chat box. We're just about finishing up here as far as the presentation itself. In starting the wrap up, Jackson, did you have anything you wanted to add?
I just saw a question come in, and it was, can we also see warpage on ortho K with the corneal topographer? And if so, what are we looking for? And I don't know if Randy or Lynette, if you guys have your thoughts on that, but I think I may not encounter it that much because all my patients, typically we have a annual 12-month replacement. So maybe the warpage is less encountered in my office, but I think theoretically, if you're comparing your baseline topography over the lens, let's say on day 1 of usage versus your topography on day 365, if there's a difference relative to those 2 readings, that may be an indication of some corneal warpage. But I don't know if Randy or Lynette, you guys have any thoughts on that too?
Yeah, if you're seeing an astigmatic shape on the front of the contact lens, and ortho K lenses are almost never toric on the front, so it should be a sphere. And if you're coming up with a figure 8 astigmatism on measuring the anterior surface of the lens on eye, then you know that there's flexing of that lens and likely could be warpage, especially if you're seeing the topography has gone from very good to less than ideal or inadequate. So why is the treatment dropped off? Is that build up on the back of the lens? And if it's not build up on the back, then it must surely be the lens itself. So doing topography over the front, if you can see that astigmatic shape, it's not maintaining its pristine condition.
Okay, very good. Any closing comments?
No, I would just thank the audience for attending and listening to us chat tonight. If there are any direct questions to either Lynette, myself, and that topographer is actually supposed to be Randy's face. So if anyone has questions for any of us, we can certainly answer. If you're interested in a topographer, you can scan the QR code. I'm sure we can find someone who can help you out on Randy's team.
I mean, one of the powerful things I think is the peer-to-peer that Jackson and Lynette offer. If you have questions about the treatment, then you have experts in the field to talk to, and that's a super powerful thing. I wish we would have had the ability to log in with Lynette on some of our early scleral fits for sure, and having Jackson's expertise on a complicated ortho case is really valuable.
That's what those QR codes are for Jackson and I. Basically, if you have any questions, want to set up time, either a refresher on sclerals or you're in the weeds with a case, you can. These QR codes go directly into our calendars, and it'll just automatically give a Zoom link for our time. There is one comment from a friend of mine who I don't know if she wants to remain anonymous, so I'll keep her anonymous. But she was talking about the AI portion, and she wanted to be a little devil's advocate. And she was talking about the time money factor to take the images versus just popping a lens on and taking a look at it. And I agree that you could play it both sides. In the past, I just popped a lens on, that was my topographer, and I'd move on to the next. But I was a one-woman show at different clinics. So if I had no CT, that was me walking the patient, taking the scan myself, doing all of that. Yes, it was a lot easier to pop a lens on for myself. However, in a busy practice and you have staff and you have the ability to keep moving and having your staff help you take the images, place the lenses on the eye for you so you can just evaluate yourself and keep moving on in your day. I think there's benefits both ways.
Excellent. Well, I want to thank everybody that attended this evening. This has been a very enlightening hour plus a couple of minutes. I think that the questions that were put in front of us to attempt to debunk, I think we did a pretty good job at that. And I thought it was a fascinating discussion. So for you attendees, please be aware that there will be future webinars by the Euclid Group and Visionary and Medmont. So stay tuned for that. And with that, I want to thank everybody, and we'll sign off right now.
Thank
Thanks,
you.
guys. Appreciate
Thank you,
it.
everybody.